Our next presenter is Janine. She is a registered counsellor and business mindset coach. She's not a business coach, she's a business mindset coach, which is very, very interesting. But she's also trained in brain working recursive therapy. You may have heard of BWRT at some point. That's brain working recursive therapy. She's also trained in brain spotting and in hypnosis. And she integrates neuroscience-informed approaches into her counseling and coaching work. Her practice evolved from a focus on trauma, anxiety, and grief to supporting adults in building resilience, confidence, and sustainable career growth, where she's increasingly began working with individuals diagnosed with or questioning ADHD. And I actually can't, I'm having a blank in what ADHD stands for again. Attention deficit and hyperactivity disorder. Who's got ADHD? Wait, anyway, Janine, welcome. Thank you for joining. Thank you very much for joining us today, and have a go.
Welcome everybody, and thanks for being here. So yes, ADHD, I almost hit my own blank there. So I'd like to reframe and look at adult ADHD beyond the label, and looking at ADHD in an adult population from screening through to real-world strategies. Thank goodness I don't have to do my own introduction. What I will talk about is, or just mention, is that I have my own personal connection to ADHD. I was diagnosed in adulthood myself, and have family members as well who are diagnosed with ADHD. So what is adult ADHD really? I'm not going to bore you with the DSM. We can all Google that or open your own DSM. I'd like to look at it from perhaps a more of an experiential point of view. It is a neurodevelopmental condition affecting how the brain regulates attention, emotion, impulse, and motivation. It is not a character flaw or a lack of willpower, which a lot of people with ADHD might hear throughout their lifetime. The core difficulty is not too little attention. It is not an inattention problem. It is about a dysregulated attention. The same person can hyperfocus for hours and hours on end, and then similarly later in the day or the next day cannot start what seems to be like a simple task. It is also about time blindness and a pervasive nervous system dysregulation. It is underpinned by measurable neurobiological differences, including structural and functional differences in the brain in various areas, and of course in dopamine, norepinephrine, serotonin, etc., which all govern the motivation, focus, and emotional control. It is very often lifelong, and this is why I'm here talking about adults and ADHD. And it is frequently underdiagnosed in adults and is often hidden behind years and years of coping strategies, shame which is developed, and being told to just try harder or just focus. So I like to use this analogy by psychologist Thomas Brown to explain to people who might not be ADHD, like what it might feel like. So think of an orchestra without a conductor. You might have an absolutely wonderful orchestra, and each section of the orchestra are phenomenal in their own right. Each musician might be a master on their instruments, but without a conductor helping to say when to play. Play faster, play slower, play louder, play softer. You can imagine that the quality of the music might not be what it should be. And this is what I think having ADHD is like. There's nothing particularly wrong necessarily with various different talents of the person, but the conductor itself might not be very good, or you need a better management system to bring it all together. So the critical point here really is adult ADHD is highly treatable and manageable, but it has to be recognized in order to do that. So let's look at the scale of the problem of underdiagnosis in adults. So the clinical reality really is that in 50 to 70% of childhood cases, the symptoms persist into adulthood and cause significant problems in their daily lives. 2.5 to 5% of adults actually meet the diagnostic criteria for ADHD. However, only 20% of that percentage is actually diagnosed and treated, which means there's a staggering 80% gap in who's actually been treated for their ADHD. So the question really is, are we looking closely enough at adults with ADHD? So I'm going to look at some of the consequences of untreated ADHD, which might help you answer that question. The psychological and mental health consequences are actually severe. Untreated people or people with ADHD in adulthood have a 3 times higher risk of attempted suicide. There's a 70 to 80% increased rate of comorbid conditions like depression, anxiety, and substance use disorders. And this is what I've seen a lot in my practice, is very often people are then treated for the depression, anxiety, and substance use, but it might not be the actual problem. The problem is actually the underlying ADHD, which has caused these conditions due to pervasive sense of underachievement and failure, the anxiety due to not being on time and getting things wrong, and of course trying to self-medicate with cannabis is very popular, cocaine, tobacco, and all sorts of other things in order to try and just regulate that nervous system and their thoughts. So what happens here is they do get treated for perhaps they're presenting for depression, anxiety, and substance use, but the treatment might not seem to be quite as effective as it should be. But that is because the root driver very often is ADHD itself. There are massive educational consequences for not treating ADHD. And you can obviously think that this is a lifelong problem starting from early days of school right through into adulthood. And so what happens is even if there isn't a particular problem that is picked up in school, people with ADHD very often have to work significantly harder to achieve comparable results to their peers. And so very often a lot of people, even if they do consider studying further and going to university, they might have gone even further if it wasn't so much of a big hassle. I've had clients, we'll speak about a little bit now, where they put off their studies and studying further. So there's a mismatch in their credentials in terms of their credentials do not actually necessarily then match their true intelligence and capabilities. But another problem that happens here is the internal limitations that they start to believe about themselves. I'm stupid, I'm lazy, I'm not as clever, which then carries through into their adulthood. There are a lot of occupational consequences. The job instability is very, very common indeed. Loss of jobs, but also getting into a lot of trouble with the managers because they're not on time, because the executive function problems and a lot of errors are caused. They also very often have interpersonal problems within with their colleagues as well as with their managers. And so what tends to happen a lot is there's a chronic underperformance relative to a capability, and very often then the career trajectory is negatively affected. And they don't quite reach the heights that they know they should be. There's a lot of relationship and family consequences. I'm just going to mention a few. This is an alarming statistic. When one spouse has ADHD, there's a 33% higher risk of divorce than the general population on top of a very high divorce rate already. When both partners have ADHD, we're looking at 66% higher chance of divorce. There's a higher frequency and intensity of conflict and interpersonal violence, poor constructive problem solving. And this flows through into when a couple might have children. It creates chaotic, inconsistent parenting, especially when a person is untreated due to dysregulation. And it creates uncertainty and anxiety in the children. Children of parents with ADHD, even if the children themselves do not have ADHD, tend to have higher rates of depression and anxiety as adults. So what's important here is a lot of small, frequent micro-traumas within the family system have shown to be as harmful as one single large traumatic event. So the adult ADHD who has not been treated, this is flowing down into the family system. There are a lot of physical health consequences. There are 50 to 60 higher % rate of obesity, which means diabetes 2 is higher. 75% of adults complain of sleep disorders, a higher risk of heart disease. And interestingly enough, poor dental health. Maybe just brushing teeth is not that interesting. Also, 4 to 9 years, lower life expectancy, and obviously greater physical risk. Think of motor vehicle accidents and all those adrenaline sports. But also, higher rates of substance abuse can also lead to those accidents. There's a higher rate of contact with the criminal justice system due to the impulsivity, higher rates of interpersonal violence, financial chaos, being handed over for debt collection and all sorts of things like that, and impulsive spending and substance use. Really, the tragedy here is we might want to think, if these adults going through the criminal justice system were actually treated, they might not be there. The bigger tragedy as well is once they're through the criminal justice system, they're probably not going to get the treatment either. And perhaps the most pervasive and most difficult to quantify is really a cumulative identity wound that is created through years and years of feeling deficient, that they're underachieving, too disorganized, or too much, or not good enough. And so there's a deep-seated low self-esteem and chronic sense of inadequacy that can very often develop, self-blame for failures, etc. And when an adult might get diagnosed then in adulthood, there's grief, because you're going to look back and think, what would it have been like if I was treated as a child? So being diagnosed in adulthood is not the end of the journey. It really is the beginning of the process of recontextualizing an entire life narrative up until this point. So why are adults being missed? Why is there this 80% gap? I'm going to run through some possibilities of why this is actually happening. The first thing is a practitioner knowledge gap. I think most people, even the general public, are more familiar with what ADHD looks like in children. And there are a lot more people to catch it because the school system, especially if they're struggling at school, might also, pick up problems. The problem is that adults do present differently than ADHD presents in children, but very often adults are not always not doing well in school. Their marks might actually be fairly adequate, and so they also slip through the cracks. Women and girls, I think the statistics I'm thinking, take 4 years longer to get diagnosed than men with ADHD. So what I like to call the next one is the no childhood impairment exclusion era. So very often those who do okay at school are not getting picked up as a problem. And this is a fundamental misapplication of the criteria because the absence of objective failure does not mean ADHD was present. It simply means they had very good compensatory strategies and the parents perhaps were very supportive or they had very good teachers. So what we should be looking at and asking when looking out for ADHD is a subjective sense of academic underachievement despite adequate grades, excessive time and effort required to complete assignments. I was one of these. I would be at varsity and I could not understand how the student next to me was finishing an assignment in a week or two, and there I was cramming in 3 weeks. and it was a lot of work, but everybody else seemed to be a lot faster. But what did I think? Maybe I'm not as smart. Maybe they just got this better than I do. And so you can see how the limiting beliefs start to actually get created. We need to be looking out for procrastination, followed by last-minute cramming. And like I said, a lot of the time, some students have parents that have been helping them long into an age where they should actually be coping on their own, where they're helping them make notes, they're helping them with timetables, they're helping them study, which is fantastic, of course, because they've kept up the grades. But then it looks like there's not a problem because all we're looking at is, oh, well, they got 70%, 80%, all is good. Another problem that I think is actually quite overlooked is a lot of adults actually don't recall their childhoods very well. So when being asked about their childhoods, which is actually very important for diagnostic criteria, because you need to remember what you were like when you were 10 years old or even 5 to actually get diagnosed, and they don't remember, so they very often just say, no, I don't think I did that. Also, there are adults that don't quite meet the diagnostic criteria. They're just below the threshold, but they do need support. Just like somebody who's got depression or anxiety that doesn't quite meet the criteria, it doesn't mean it's benign. And very often, adults have created and found ways to cope over years and years. But what happens is they get a promotion, or they go to university and there's less structure, or during COVID, remote working, and suddenly, where was the structure? Or a relationship breaks down and they cannot cope. And so they present in doctors' offices, their psychologists' offices, and counseling because it looks like an adjustment reaction. But their system is so overwhelmed, there's no more capacity to cope because they are just barely hanging on as it is. Compensatory strategies also hide a diagnosis, right? Sometimes a person with ADHD can come across looking very organized, super punctual. I will arrive an hour early because I'm not good with time, but then of course I also waste a lot of time sitting around waiting. But then it doesn't look like the typical presentation. Or you get those that are super organized. The problem here is that they cannot deviate from the structure, and when something changes, the wheels come off. So what happens is the compensation is visible, but the underlying impairment is not. So it is very difficult to pick up adult ADHD in a person that has created these types of compensatory strategies. A number of articles point out some DSM shortfalls. The DSM for ADHD was built for children and around children, not adults. And of course, as the time has gone by, there's been some revisions, and you need a few less criteria as an adult, but it's not really adequate to represent adult ADHD and how it presents. One of the articles I came across suggested 6 additional domains that the DSM should actually be considering because they are inadequately represented or not represented at all. Disorganization, forgetfulness, and struggles with their task initiation. And the bottom 3 are not in the DSM at all. The emotional ability. I don't know any person with ADHD that doesn't struggle with this. 75%, in our earlier statistics, are struggling with sleep and time perception difficulties. None of these appear in the DSM criteria. Comorbidity often overshadows a diagnosis, so a person will be presenting with suicidality, panic, depression, anxiety, substance use disorders. And with these kinds of comorbid conditions, the condition with a greater acute distress becomes the focus, and then we stop looking. Meanwhile, underneath is still the ADHD, which also does not get addressed. So what I would like to propose is looking at this iceberg, and I think the public perception is You can't focus and you can't sit still, and that's ADHD. But it's really a lot more. If we look below the iceberg, I think this is where we should start screening adults. The higher, if you think of the comorbidity rates of 70 to 80%, anxiety, depression, substance use, etc., why are we not screening for ADHD when these other comorbid conditions are presenting? Financial problems, sleep problems, relationship difficulties. Interestingly enough, women, because of the lower estrogen at certain times of their cycles, they present with far more severe symptoms of postpartum depression and PMS and menopausal symptoms. Interestingly, women who get diagnosed in adulthood are most often diagnosed in perimenopause. So I think, is to look at this and start thinking, how can we close this 80% gap? And I think it starts with screening when we start seeing the comorbid problems and conditions that adults are presenting with. How often, unless somebody has actually already been diagnosed with ADHD, does an adult sit down in the doctor's office or in the therapy room and say, I think I have ADHD? They might come and say, I'm anxious. They might say, I'm depressed. They might say, I've got relationship problems. But very seldom do they even know or realize they themselves have ADHD. Also, when treating children, my question is, why are we not educating adults about their own possible ADHD? ADHD is more likely to be more hereditable in ADHD than it is for anxiety or depression. We should be screening the parents, because if the parents are not treated, we go back to the family problems and they can't manage their children as effectively. So much about doom and gloom. Let's look at what we can do. The screening. The ASRS is freely available. It's very quick. It is very easy. It takes 10 minutes for your patient or your client to fill it out. It has a high sensitivity, so meaning it's going to definitely catch those people who have ADHD as adults. Unfortunately, a poor specificity, so it might flag with those who don't. I think what's worth here is, if your client is, or your patient is coming up as moderate to a high chance of having ADHD, refer or do a full diagnostic interview yourself. But I think it's well worth taking 10 minutes at no cost, other than a little bit of scoring time and 10 minutes from the client. The DIVA is also very good and has a nice gold standard here of high sensitivity and high specificity. I think the problem here might be, time-wise, you'd actually have to carry out this interview yourself. The earlier versions of the DIVA are also freely available. I think the DIVA 5 you actually have to now pay for, but the earlier versions are still very good and relevant. So from a time perspective and a cost perspective, I don't think there's any reason we shouldn't be screening, at the very least. So now, maybe your client or your patient is now diagnosed and they have ADHD. What do we do now? Let's look at some strategies and some real-world solutions. And I'm going to propose that a multimodal solution is really, really important. Medication is obviously first-line treatment, but there are limitations. It sometimes leads to adverse effects in some people, or they might not be able to take the medication. There's a partial response, and a chronic residual symptoms might still remain. It also doesn't catch those years and years of limiting beliefs. It also can be very expensive and not affordable for many people. I think you're looking at between 560 to maybe even over 1,000 Rand a month. The government system does not give adults ADHD medication, and sometimes there's a lot of stigma around taking these meds. Research has shown that using pharmacotherapy plus psychotherapy or coaching has definitely the best outcome. So it's really not an add-on, but a requirement, I think, to be looking at non-pharmacological strategies. And there is evidence to show that they are actually effective. Mindfulness has shown to be the best strategy, most effective in adults. CBT and DBT, no surprise there. Organizational skills and training, which are really, really good in terms of trying to help get past those that disorganization. Psychoeducation, I was surprised to find this out, but doing a good psychoeducation significantly reduced the levels of inattention and impulsivity. Physical activity, obviously working on that dopamine and norepinephrine systems, but also nutrition supplements, omega-3s, vitamin D. Research shows that people with ADHD have higher risk of being short on vitamin D. So what I did is I used the evidence and I created 6 cornerstones of integrated self-care to help support people with ADHD, especially adults, but I think this can be easily adapted for a different age group. So look at that mind and mindset, when you look at your identity and all those limiting beliefs that lead to depression and anxiety, sleep, regulating the nervous system and emotions. So here, this is where mindfulness comes in, and breathing, and other wonderful things that you can use. Even weighted blankets for adults are great to regulate. Time management, very, very important to work that procrastination, as well as nourishing and moving the body. And obviously the outside environment is very important. I think, working in an open plan office as somebody with ADHD is probably one of the worst things officers could have done. It's very distracting. So teaching people with ADHD how to adapt their environments in a way that they can function better. It is important that a deficit in one of these cornerstones will affect the others negatively, but conversely so, where there are cornerstones that are strong, it helps to support in other areas. So what I want to talk about, and Megan mentioned that I'm trained in BWRT and brain spotting, and I want to mention these because they've been integral in terms of really helping those cornerstones come together in like a really solidified and long-lasting way. So let me introduce them. Oh, just a note, they are not yet evidence-based, and I say yet because the research is coming out, but I always say EMDR and CBT had to start somewhere. So brain working recursive therapy was developed by Terence Watts in 2011. It is grounded in a neurological model of how the brain processes and responds to threats. And the central premise is that many psychological difficulties, including trauma, anxiety, shame, emotional reactivity, is really driven by a dramatic and quick survival response. So if you're thinking fight and flight, that's right. But they occur, and all those signals in the brain and all the corticosteroids, etc., being released before we are even consciously aware of the state that we are in. And BWRT works by interrupting this automatic style and installs a new preferred neural response in its place. So I thought, let me do a diagram because it's difficult to understand this if there's nothing to see. So for example, think of a client that is petrified of, studying further. They think they're going to fail. It sounds overwhelming. And that would be the stimulus or the trigger. And what BWRT is interrupts that perception and that feeling, the fear they might even feel in their body. And once that initial trigger is disrupted, the part of the process is then to loop a preferred response. How do we want to be thinking and perceiving? And importantly, a future perception of themselves actually completing the task in a different way. Visualization here is very important. Research shows that visualization really does create new neural pathways. So the BWRT then actually creates a new neural pathway. I don't think it blocks the old pathway. I think it creates a new one. And so the person has a new perception of themselves in relation to, for example, to what they might be fearing. I've used this very successfully around studies, public speaking in one session. One session. So here's a little bit of evidence coming through. In 2017, there was a study on people with PTSD. The BWRT was found to be non-inferior, so equal to EMDR, producing equivalent outcomes in one session, compared to 8 to 12 sessions of the EMDR. And these results were maintained after 6 months. Another study in 2025, so very recently, in patients with depression, one session of BWRT, they found there was a 66% reduction in the depression scores. That's a huge, huge reduction in one session. Think about how expensive, it is to go to a psychologist. So one session is fantastic instead of 3 years. Other things that improved, the emotional regulation, restored personal agency, and that greater future orientation, which is a big part of BWRT, really building hope for the future, which is really, I think, important when working with clients who are depressed. Let's look a little bit at brain spotting, checking my own time blindness. Brain spotting was developed by Dr. David Grant in 2003. I'm not sure it's exactly an evolution of EMDR. Perhaps it is. I think David Grant would disagree. He was a master trainer in EMDR, but he believes that brain spotting is actually quite different. But nonetheless, they both use the eyes to process trauma. There's a difference in that brain spotting uses a fixed an eye spot rather than using a bilateral stimulation in an eye movement. There is a theoretical basis that trauma and emotionally charged experiences are stored subcortically in the midbrain, limbic system, and into the brainstem, connecting somatically with the rest of the body. And these structures are activated by a specific eye position. And once the brain spot has been located and and the person is connected with that, it is the premise is that you're then able to process that trauma, for example, on a subcortical level, where perhaps talk therapy is not always able to reach. What's very nice about brain spotting, also BWRT, is it's not necessary to always speak about all the details of your trauma, which I think is sometimes very nice, depending on the trauma and even shame. So there's a little picture of brain spotting. In front of you, there would be a spot that your therapist or counselor would help you find. They also use bilateral stimulation for music, which helps with the process. Some evidence coming through, 3 sessions of brain spotting was found to be equal to 8 to 12 sessions of EMDR, and this was a study done on clients with PTSD. Another study in 2023, they did a survey with therapists who were trained in both EMDR and brain spotting. 82% of the therapists believe that their clients responded better to the brain spotting. 72% also felt that they felt more proficient with brain spotting than they did with EMDR. They felt, I think, it was a lot easier and more simple to work through. Interesting, what else they found is that over and above treating the PTSD, daily functioning and depression was also improved after 6 sessions. So how does BWRT and brain spotting fit into working with ADHD? It's very friendly for ADHD. It's brief and it's highly effective because people with ADHD sometimes want results today. So it's nice in terms of a dropout rate. There's no homework required like CBT and DBT, so we don't have to add on to that executive dysfunction and struggling with time. You can be very specific on what you want to work with, a specific trauma, for example. And because you don't have to always explain in every detail what you are working through, you can actually bypass that shame. A lot of people do not enter a counseling room or speak to their doctors because they are actually feeling quite ashamed of their lack of performance and how they're struggling in their life. They are both effective with those comorbid conditions. In fact, BWRT and brain spotting have specific processes, both of them, for working with substance use disorders. And in general, very good to calm the nervous system. And of course, with all of this, it's going to help you improve your sleep. So how does this all fit in with those 6 cornerstones? Because the BWRT and brain spotting has really been, I don't know how I did anything without them before, to be honest with you. Both of them are fantastic at changing those negative beliefs. So mind and mindset, and really, helping to develop a growth mindset, which is very important to do well and really function optimally in life. It definitely helps with time management. A lot of procrastination is due to nervous system dysregulation and fear. Fear of failure, fear I can't do it, fear you're going to get into trouble. And so these modalities are very good in that regard. And of course, it's all very well to say, let's get a schedule and follow it. But if you're so dysregulated and so anxious, you can't. So very important that you work with those so a person can actually follow through on their schedule. It helps to resolve a lot of trauma. Research shows that with adults, or any ADHD for that matter, there's a higher risk of trauma. So you'd probably be treating some trauma along the way. So it fits in beautifully with almost every single cornerstone. And I really think it has been absolutely fantastic in my own practice. I've been using them both for over 10 years. And I have seen a lot of success. So let's look at an iceberg again. And instead of all the problems, let's look at the strengths. I think ADHD people are highly enthusiastic. They can think out the box. They are creative. They can be impulsive, but I think managed well, there's a calculated risk-taking, which I think can do very, very well. They can make very good entrepreneurs. And instead of being, hyper-focusing to a point that it is dysfunctional, it can be managed to be used in a very, very productive way. And I think, just building adaptive resilience, I think is all about bringing out the strengths of the person and not just looking at the negative. But of course, we need to recognize it first. There's a massive gap. And I think the consequences of not treating adult ADHD are pervasive across the medical industry, parenting, education, etc. And so just a few notes. I've had clients from all sorts of different walks of life, from, engineers to students doing their masters, people in finance, people in the medical industry that have, always felt that they could do more, could do better. It could be less stressful. And I've really helped a lot of those clients make things and life a lot easier, not only in their occupation, but in general in their personal lives as well. And it really does make a big difference. Even if they're doing fairly well, there is a whole lot of potential that is untapped when the adult ADHD is not managed well. Thank you, everybody. Any questions?
Any questions from the floor? There we go.
Thank you, Janine. That was absolutely brilliant. And your slides were amazing. So,
Hyper-focus on with Notebook LM. It's my new...
I was just wondering.
My new obsession.
Can I just ask, what is the oldest patient that you think are worth seeing? Because if you go to retirement homes and old age homes and you start looking again, they are full of people like this. And I don't know if you would know the answer to this question. How old a person could you start on medication like Concerta?
Well,
I don't think there's
that
evidence.
you'd need to ask a medical doctor in terms of the actual medication. I'm a registered counsellor. But I do believe it's worth looking at, because the dysregulation causes a lot of problems within relationships and not coping and not managing. And already, as you get older, there's already a mental and brain decline. And I think getting help, why not? Even it doesn't matter how old you are, I don't think. Does it matter if you're 50 or 60 or 70? If you can make someone's quality of life better, I think it's worth looking at. Yeah. I mean, obviously, it would need a very careful differential diagnosis because obviously there are other issues to be looking at, but I do still think it's worthwhile looking at for sure.
I think we've also got to consider that there's not just pharmacological options. And the BWRT and the brain spotting seem to be very cost-effective and time-effective options, which are valuable. One last question.
Just a quick one. Without intervention or any treatment, does adult ADHD get worse over time, or does it stabilize, or does it just improve on its own?
Well, the stats show that, from childhood cases going into adulthood, that there's a bit of a variety of the percentage, so between 50 and 70% follow through into adulthood. I think at different stages of life, it could be different. Women that go into different phases of their cycle when the estrogen drops definitely feel that drop of estrogen because of the role the estrogen plays in dopamine. And of course, especially women going into perimenopause and menopause with like a 60% drop in your estrogen, this is where a lot of adult women start getting diagnosed because all the strategies that they've created over many, many years are just not sufficient anymore. And then it comes out. So in those cases, I would definitely say I feel a lot worse. I'm one of those.
Janine, thank you very much for spending time with us and for talking to us about pain, another pain, about something that's under-recognized in the adult population, where it's quite spoken of quite commonly in children. So Janine, just a small token of our appreciation. Thank you.